Thank you very much. Unfortunately, our next speaker, Dr. Wishmeyer, cannot be here today unexpectedly. So we're going to move forward, and Angus Scrimgeour is going to take over from here. Do you know how this works?
The green one. Thank you. Thank you. Good afternoon. I want to thank the organizers for inviting me down to speak at this session. I work up at the USARIUM, the United States Army Research Institute for Environmental Medicine. We're about 16 miles west of Boston, and we study soldiers in real time, in heat, in cold, at altitude, and in my area, I'm in the Military Nutrition Division. The focus of my work is in preclinical models for traumatic brain injury, or TBI, and to look at pathophysiological mechanisms and then look for gaps where pharma is not addressing the solutions, and perhaps there's places to insert nutritional options to put into our soldier rations or to put into combat casualty care for this captive audience. Are there ways we can identify nutritional deficiencies that set them up for failure and hinder return to duty in the soldier? This is our standard disclaimer that really says that I'm speaking for myself and I do not purport to speak on behalf of the Department of Defense or the Department of the Army. My outline in 20 minutes, my wife thinks I can talk for 2 days, but I've got 20 minutes. So I've broken it down to really focus on what I have in my right hand here is our Bible. Eight years ago, the National Academy of Sciences, Institute of Medicine organized a meeting bringing in world experts to talk on nutritional therapies for traumatic brain injury. This book came out it's 430 pages. It came out in 2011. So I thought that really to bring you up to speed on where we are in traumatic brain injury, that I would address what these recommendations were, what's gone on from animal models, where we are in human preclinical phase 2 studies and phase 3 studies, and which are our candidate best nutrients to help the soldier. I remind you that soldiers may be exposed to blast traumatic injury, which is very different from what Rob Gronkowski, the New England Patriots, gets, where it's in the playing field, or a non-blast injury like a motor vehicle accident or young girls playing soccer. So my outline today, I will give you a definition of the problem. How big is it? Is it just 3 soldiers or 3 million soldiers? Are we going to change the rations for 3 soldiers? Then go into these recommendations, define the problem, then go into the recommendations from the Institute of Medicine, and then get into are we going to be at physiological or supraphysiological when it's no longer considered just a nutrient for the soldier? And then I have one slide to wrap it up. I have 2 Venn diagrams here to kind of introduce the problem. On the left, I've given you what happens in US high school athletes. And there's levels where we can diminish these numbers. If 51% of high school concussion is in football, there's possible rules that we can implement to reduce that number or change the safety and change the helmets. The same applies for our soldiers. So we look and see if we can overlap, because if the pathophysiology of the disease is the same, we change helmets in both groups, we can also change nutrition in both groups. So there is room for overlap, and it's also in our grants. So we can't do all of this ourselves. We look out to universities to see if we can partner to help our soldiers. Noticeably, that in the blue, 13% of the injuries are in high school girls. As they get older in high school, they start banging heads and to try to get into college and get a soccer scholarship. So we have concerns between. We have overlap, and we have places where we think nutrition can have, if it's beneficial. The right-hand diagram shows you our concern in the DoD, and that at least 82% of the injuries are in the mild TBI/concussion. Of note, many of these will resolve by themselves within a year. What slows that down is the fact that 70% of the soldiers diagnosed with TBI are still getting prescription-strength ibuprofen 6 months post-injury. So we're looking at that now in preclinical models to see if giving the wrong medicine, possibly for a knee injury, is exacerbating or slowing down the return to duty. Below the diagram, I give you an idea of how big this problem in the United States. And about 87% of these injuries are treated in emergency departments. And you note that as many as 52,000 will die from a penetrating or severe traumatic brain injury. For the DoD, the Department of Defense, if we count the numbers OCONUS, meaning overseas, related to the two wars of note, a lot of these numbers are mild TBI or related to blast. And to give you that number, then we're looking at about 380,000 soldiers suffering with mild TBI, and the best we have for them is ibuprofen. The numbers, what it costs the country in billions, is innumerable, but I can tell you that the DoD has spent over $940 million on TBI research, and we still have nothing to give the soldier because we're still developing the best models. I will tell you that I'm not in the business of fixing busted rats. My custom is a busted soldier. So I'm seeking help. I'm looking for advice. I will take anything, and you can get my email. The DoD does do a pretty good job on epidemiology. So this is ICD-9 codes, and it's tabulated from the start of the war in about April 2003. And then you'll see that the weapon of choice was this roadside bomb. So starting in late 2007, the number of soldiers exposed to IED increased, and I've circled the year 2011 to show you the numbers. As many as 600 cases newly diagnosed per month. What might look good to you is that the numbers have decreased over time, of late. This goes out to January of 15, but I have the numbers up to the second quarter of 17, and the numbers are down to less than about 50 per month. And the reason we have fewer incidents is because we brought the soldiers home, not because we've given them a zinc helmet or we've up-armored the vehicles. It's mostly because the soldiers are now CONUS, meaning back at home. But this reminds us that if this is the weapon of choice, it'll be used in the next war. So we need to be planning strategies for either prophylaxis or improving treatments in our soldiers. The way we code it is important. This is an old system that has been around for about 40 years, mild, moderate, severe traumatic brain injury. And if you go down to the third line, it's an altered or loss of consciousness for less than 30 minutes. So if my daughter playing soccer is unconscious for 29 minutes, it's considered mild TBI, which I find perhaps it's time with modern imaging facilities, perhaps there's time for us to recategorize this and look at other ways to put this in silo, who's getting treatment or not. I've added a little piece on the bottom to give you the numbers for the Army. About 82% of our soldiers are diagnosed with this criteria of a loss of consciousness of less than 30 minutes as being mild TBI. So I introduced the book, the Bible, for us, and what I'm going to get into now is the summary of recommendations. The panel of experts, people came from all over the world looking at specific nutrients. And for me, this is the weakness, because we had people from Johns Hopkins focusing on dark chocolate and people from Florida State focusing only on zinc. And I have to believe that they've done very well in pathway A or pathway B or pathway C. But for me, coming late to this picture, I've looked at maybe there are combination dietary options that we can do. So in my lab, where we develop preclinical models, we're doing combinations of omega-3 and zinc and vitamin D, and I'll get into that. So a priori, the number one issue coming in is when a soldier is exposed to a blast 2 hours north of Baghdad and he gets helicoptered into Baghdad, he's not provided any nutrients in that time period. So the nutritionists from the combat zone came in and said, it's protein. If we can just get beyond an IV line, can we get protein to the soldier, give him a Nestle Boost or some type of nutritional recommendation? Once they're in a cache in a combat hospital in downtown Baghdad, they get in an enteral tube or a total parenteral nutrition because the kid is unconscious. Those lines get pulled because he's going for MRIs or CAT scans or PET scans, which can be done in downtown Baghdad now. Within 6 days, he is medevaced to Langstuhl in Germany, and again on the plane, he's not going to be provided nutrition for those 7 hours. But it's Langstuhl, or it's when he's back in Walter Reed, that we start to optimize protein. So at the macro level, protein was the recommendation. So we looked at which were the best nutrients, I'll get to that, but big picture, we don't yet know which nutrients are deficient in our soldiers when they're overseas subsisting on MREs, the meals refused by the enemy. MREs are military. So We don't yet know. They're not supposed to eat this legally for more than about 12 days, but we know they will subsist on MREs for up to 30 days at a time at the beginning of the conflict. And can we improve on what's in those rations? So there's a need to do dietary assessments overseas. Here we can do it on the bases. And then in the community that so many of them are exposed to blast, what are the deficiencies? Are there deficiencies that predispose them, as I said, but are there pieces that are missing in the treatment plan? So I have 10 minutes. Coming from an endocrinology background, I am concerned about this slide. The recommendations were to look at blood glucose as, is it going to be elevated, hypoglycemic because of total parental nutrition? And if so, should we be doing intensive insulin therapy and administration of insulin to a soldier who's possibly having cognitive deficits, and now you've given him insulin, which may make him hypoglycemic, and he confuses that with balance issues, and this whole scenario is rife or set up for failure in our soldiers to give him too much insulin, and now we have him in a hypoglycemic coma. In our own models, when we've done blast and non-blast, and we've measured peripheral blood glucose, we see no change in blood glucose that would require insulin interventions. All right. I'm going to break down a few of the key ingredients that were recommended by the Institute of Medicine. And this was a trial run out of Harvard by Ross Saffon's group looking at choline. And the recommendation was to take the success stories from preclinical animal models and go to phase 2 and then get into phase 3 clinical trials. So acetylcholine, as you may know, is found in eggs, beef, liver, milk, yogurt, and cruciferous vegetables. So Ross Saffon's group got the funding for this, a phase 3 clinical trial with 1,200 study participants. And here's the first breakdown. The problem is when you're picking out complicated, mild, moderate, severe TBI. Pick any subject who wants to come regardless of sex or gender or age. And then they're randomized to receive 2,000 milligrams of acetylcholine for 90 days. This 4-year trial was terminated due to early futility. Subsequently, no further human trials have been conducted with acetylcholine. If I want to cut this short, I'll tell you that we have nothing that's working so far. We are expecting, we're looking for some results, I'll discuss that, but we have nothing that has translated from success in animal models to the human studies. Creatine was a strong recommendation from the Institute of Medicine. We see what it does in sports athletes to recover muscle injury, and the idea is that the muscle is a brain, is a fallacy, but perhaps there's place for human trials with creatine. But to date, since this book was published, no human trials to date have been conducted, and currently there are not any human trials in the process of evaluating. I looked last week on the clinicaltrials.gov network under traumatic brain injury, and there's nothing matching with creatine and traumatic brain injury. So this is where we have a bit of hope. If our soldiers are on a high-fat Western diet with too much N6, and this is your building block in the brain, and the brain gets busted in a blast, and the wall falls down. When you rebuild that wall with N6, maybe it's not desirable. Perhaps we can change that through diet, whether it's prophylactic. In my lab, we do, in treatment, we're using omega-3, a DHA-EPA mix, to see if we can rebuild the brain and help with cognitive deficits. All right. So currently there are 3 double-blind randomized controlled trials looking at a mix of DHA or DHA and EPA supplementation, and I've listed the 3 universities that I'm aware of. East Carolina is looking at 62 NCAA Division I athletes getting 2.2 grams of DHA for 30 days. This is a scientific term that's a shit bucket of DHA, and it's almost medicinal. The study ended in July last year, but no preliminary data to share with you at this point. The University of Texas Southwest is looking at children supplemented with 2 grams of DHA for 12 weeks and measuring time to return to competitive play. This is key. We look at the similar measures in our soldiers, return to duty, or the athlete return to play. The study is expected to end in about 3 months' time. And then finally, the University of Michigan is doing the Optima TBI pilot study with 50 adults, it's mild TBI concussion, and giving them 6 grams of DHA and EPA for 1 month, followed by 1.2 grams of DHA EPA for 2 months. So This is where we look to others for strength and what their recommendations are, because the nutrition is going to be your lifetime of repair. So if it's a combat medic and he gets a shot glass of DHA and EPA versus physiological amounts of DHA and EPA, changing his dietary habits over a longer term, we see that as being beneficial. So my rat studies will go out to 30 days and 60 days to see if we can simulate what we're going to be doing in soldiers. All our preliminary published studies to date have been in zinc. And we start this by looking at what's deficient. So in a mildly zinc deficient rat, we don't see recovery following blast. This is blast from an explosive blast or TBI from a drop weight cortical contusion injury. On low zinc, the animals will not recover. We focus on the biochemistry and the behavioral repair. To date, no human studies have been done since this book was published. I can tell you that back in 1968, 1969, the group out of Kentucky was doing human trials and looking at humans with TBI and noticing that they were hypozincemia, so possibly there's a place for intervention in humans. All right, quickly then, we've got the list of research recommendations. Uniformed Services University of the Health Sciences in Bethesda was looking at ketogenic diets in rat models. The curcumin or turmeric has been studied by the Indian Army, and to date nothing's been done in humans. And the resveratrol or red grapes, we're looking at where does it work? Where can it help us? So the curcumin I can summarize by saying that no human trials to date, and there are currently not any human trials in the process to evaluate the effects of turmeric and concussion. Same for resveratrol. There is a study going on at University of Texas Southwest Medical Center, the REPAIR study, looking at 500 milligrams of resveratrol in boxes. The study was double-blind. It is completed, but it has not been published. So vitamin D, this is our biggest disappointment coming out of Emory University. Donald Stein's pioneering work looked at female rats would repair faster than male rats. So he started doing progesterone into rats exposed to TBI. And a postdoc happened to add vitamin D to the mix. When I've spoken with Dr. Stein at Emory, he tells me they see vitamin D as medicine. So we took that and we've been adding vitamin D to fight the depression and dementia possibly in our rats. So it is analogous to what we would do in soldiers. We look forward to the results of his outcome, of his studies. And it's based on this schematic that in a vitamin D deficiency, we have increased neuroinflammation. And this would exacerbate the TBI, the mild TBI severity, possibly increasing PTSD symptoms. So this was NIH-funded work, vitamin D in combination with progesterone. And I'll draw you down to point number 4, that the 2 studies that were conducted, they were suspended due to lack of efficacy. So again, we have failures. Donald Stein wrote a review of this, critical of the study design, that they were heterogeneous. They took 6-year-olds and 60-year-olds, people who were hit 6 days ago and 6 years ago. It was a panacea for all kinds of TBI, and we blame the failure of the study for not being circumscribed to possibly college girls playing soccer. So lessons learned. To summarize, I've got evidence-based nutrition guidelines are lacking. Which nutrients will benefit and what are our biomarkers? So Dr. Stover mentioned this earlier, biomarkers. We don't have decent biomarkers for traumatic brain injury, so what are we going to study? Are they improved because of the nutrients? And which of those biomarkers would respond to the nutrients? To make it worse, to exacerbate the situation, just briefly, we have an overlap. This is a list of symptoms. And if you look at this, many of these are also seen in the syndrome of PTSD. And are you treating it as a combination disorder disease? And is there ways that are TBI specific? When we've looked at 14,003 soldiers with TBI, only 1 out of 14,003 were hit by a blast and nothing else happened. It's really common then to have polytrauma. So the soldier gets hit by a blast and a roof falls on his head, or he goes into a building, or he loses a leg, or he gets shrapnel. And when he comes into the ER, that's what's treated first. And since you're not bleeding out of your ears and you've become deaf, the physician will address the shrapnel or the second disease, not the TBI. All right? So just in brief, two overarching research gaps. The intervention should be selected possibly to treat the symptoms. If we can't get a large molecule to cross the blood-brain barrier, how are we going to fix the brain, if we can ever fix the brain in a person of my age? So rather, can we treat the balance problems or the sleep problems or anxiety problems that come along with the TBI symptomology? The second point is possibly more important for me, that combinations may work better than nutrients, single nutrients. And if we haven't even done the single nutrients, we're still away from getting to combination therapies. To wrap this up then are we going at physiological or pharmacological levels? This schematic, this histogram is dated, but it shows you the number of studies funded by the NIH to look at neuroprotective agents in gray and neurotherapeutic strategies in black. So it's a total of about 37 phase 3 clinical trials with 0 success. And this has continued. All right. The way we see this, these are just two short examples that the I'm referencing vitamin D and then the omega-3 problems, that 1/3 of vitamin D supplements tested met the standards requiring pills to contain between 90 and 100% of active ingredients. The range was from 9% to 146%, and I got a reference there for you. Something similar for DHA and EPA, the omega-3s. So when the USDA looked at this, they have recommendations for 250 to 500 milligrams a day, and this is with recommendations from the American Heart Association. Estimates of dietary DHA and EPA intake for Americans are 90 to 100, which is less than 50% of the RDA. So the American diet with a high N6 is something we ought to fight in our soldiers too. All right. This is not my schematic. I stole this. And this is something ideal, that remember that the injuries are never the same. When I was trying to set up preclinical models, I asked, what's the most common injury? And some soldiers are hit from below or from the side, or it's penetrating. There's such a variety of injuries. I just said, all right, we'll just go with explosives. And it would be really nice if we had something like this where, depending on where your injury is from, we know what is disrupted. Is the cerebellum, so you're having problems with balance? And then there are specific nutrients. So this would be really nice if I had data to support a slide like this, and that this is my wrap-up. Now, in conclusion, the chronic neurological deficits of TBI are complex, and clinical treatments are limited. Several clinical trials have failed because of the heterogeneous population. Patients with a wide variety of injury severities were grouped together in the same studies. The ongoing failure of clinical trials for TBI has questioned the direction of therapy. And finally, it's quite possible that you're giving the right pharmacy drug regime in a person who's nutritionally deficient. So maybe we've got to be doing combinations of working with the drug companies to do nutrition interventions in combination. I thank you for your time. That's it.